Good evening, everyone. Thank you for joining us tonight. My name is Lauren Steffes. I'm the marketing specialist here at OSMS. Tonight, we're here with Dr. Darren Nabor to talk to us about hip arthroscopies, otherwise known as a hip scope. So just so you are all aware, we are recording this webinar and we'll make the recording available on our website at osmsgb.com/webinars by next week. If you have any questions, please leave it in the Q&A box, and I will be asking Dr. Nabor your questions after he gives his presentation. But before I turn it over to Dr. Nabor, I just have a few fun facts that I want to share about OSMS that I'd like to go over with you, and then I'll turn it on over to him. So first, if you want to go to the next slide, Dr. Nabor. So if you're not already aware, we're a doctor-owned orthopedic, sports medicine, rheumatology, and pain management practice. We have 9 locations across Northeast Wisconsin. Our farthest north is Marinette, farthest south is Fond du Lac. Recently, actually this past Monday, we opened up our very own clinic in Oshkosh. So we moved from Mercy Medical Center, actually right next door. So 200 South Oakwood Road is where we're located now. That is one of the 2 places that Dr. Nabor sees patients at. The other one is our Neenah location. And then out of our orthopedic sports medicine physicians, we have 26, 8 rheumatologists, and then 3 pain management physicians. We have a full range of on-site diagnostic services, which makes OSMS really a great one-stop shop. So we have X-ray, MRI, CT scan, which is for extremities only, DEXA scan, which is for bone density, and then EMG, which helps with getting orthopedic injuries determined. And then we also have infusion suites on site at our Marinette, Green Bay, Neenah, and Oshkosh now, that location as well. Our surgery centers we have in both Neenah and Green Bay. And then we have walk-in injury clinics in Neenah, Green Bay, and now Oshkosh as well. And then, of course, all of our main locations, they also have physical therapy and occupational therapy partners on site. If you are ever in any pain or have an injury that you're just not sure whether you should make an appointment for, we do have Ortho Access by OSMS. It's a free service that anyone can use at any time. Where you can get free injury advice 24/7. You just go to this QR code and then start your chat online, and you'll be connected with an orthopedic expert, and they'll be able to answer any questions, giving you tips on what you should do next, whether you should schedule an appointment or, hey, try these at-home remedies. That might be something that'll work for you. And then lastly, we have extended our hours in Green Bay and in Fox Valley. So that's both for our orthopedic and sports medicine clinic and our walk-in clinic. So you can now be seen Monday through Thursday until 7 p.m. And then Friday is still 8 a.m. to 5 p.m. All right, so now I will turn it on over to Dr. Nabor. And if you have any questions during his PowerPoint presentation here, you can put them in the chat. And then, like I said, we'll be able to go through those questions afterwards.
Well, thank you for joining me tonight. A little bit about myself. I have been practicing for about 6 years now. I did my residency training in Milwaukee at MCW, Frederick Medical Center. And then I did an additional year in sports medicine in North Carolina at Wake Forest University, where I had a lot of specialized training in the hip, in particular training in hip arthroscopy, which is a relatively unique procedure. Not a lot of orthopedic surgeons do or know how to do. I perform these procedures weekly, and I probably have done anywhere from 400 to 500 hip arthroscopy procedures since I've started. So it's a very common procedure that I do weekly that I'm proficient at. So I'm happy to talk to you about this today. It's kind of a broad subject, but I really want to talk about, who would qualify our hip scope, or what type of pathology or injury does it treat? A lot of people, I think, are unaware of what it actually does. A lot of people are very commonly hear of a knee scope, where they go clean up a meniscus tear. Hip arthroscopy or hip scope is quite a bit different than that. So who are the candidates I'd like to cover? How is this procedure performed? And really, what is the recovery like? Because that's one of the more important patients ask me daily is, if I have this surgery, how does this affect my lifestyle, and how long does it take to get back to my active lifestyle? So this picture right here, you can see the way we do this, we stick a scope right into the hip joint just through keyhole incisions, and we can do a lot of treatment for hip pathology through a very minimally invasive technique. So the most common pathology or the most common problem that I see that are candidates for hip arthroscopy is a diagnosis called hip impingement, and that is often associated with a hip labral tear. So to really understand what that is, you got to understand the hip anatomy. So if you look at this picture on the top of the screen here, this is a hip joint right here. You can see the hip involves a femoral head, which is the ball, and it involves a cup, which is we call the acetabulum. Normally, somebody with a normal hip, that ball and that cup or the acetabulum, when they rotate, there's no impingement and the ball matches the socket perfectly. Unfortunately, there's a lot of people who are born with altered anatomy just based on their genetics, nothing that they've done wrong. But what can happen is they can form or develop extra bone on their ball, which we call a cam lesion, or they can develop extra bone on their socket, which we call a pincer lesion. And what happens when that hip rotates, the ball and the socket collide and it pinches those two bones together, and that can cause significant hip pain. A lot of the times we call it a combined lesion where people that have hip issues with hip impingement, they both have the extra bone in the socket and the ball, and those two bones pinch together, leading to pain and dysfunction. The other thing to note is with the normal hip anatomy, we all have a hip labrum, which is like a ring of tissue made out of cartilage, almost like a piece of rubber that acts as a gasket that keeps that hip stable and helps its function. And sometimes when that ball and the socket collide because there's extra bone there, it can lead to a tear. And typically when the hip labrum tears, it can be very painful. And sometimes it's comes on with really no injury whatsoever. So I often get the question, what symptoms would I have if I had a hip tear or if I had a hip impingement type symptom? Typically, people with hip joint issues, it's in the groin, right in the front of the hip. I have people come in to see me daily where they complain of their hip pain. They'll kind of point to their outside of their hip or their backside of the hip. Most of the time, that is not the joint causing that. Typically, people with hip impingement or a labral tear or even hip arthritis, most of the time it's right in the front of the hip near the groin location, and that can be very debilitating. Any age of patient can get this. I've seen teenagers as young as 10 to 12, all the way up to weekend warriors in their 50s and 60s develop this hip impingement and labral tear at some point in their life. And I often get the question, how does this start? Why am I experiencing this? Most of the time, it is due to your genetics, and it's just how that hip is formed that has predisposed you to developing this impingement, which can lead to that tear. It can happen from a traumatic injury, such as a sports injury, a car accident, something like that. But most of the time, it truly is your anatomy that predisposes you to develop this type of symptom. And how is the diagnosis made? A lot of the times it's physical exam. When I see people in clinic, just looking at them, describing their symptoms, tell me where it hurts, I can usually make a diagnosis that it's a hip impingement type syndrome or a labral tear, just how they describe their pain. To truly make a diagnosis, it requires x-rays to look at the bony alignment, as well as an MRI of the hip that shows the soft tissue structures to look for a labral tear. So we usually, when you see me in clinic and I'm worried about a labral tear, I'll start with getting x-rays. And if those are suspicious looking for hip impingement, I will order an MRI, which usually confirms that you have a labral tear. So the question I get often is, who is a candidate for surgery? I see people with hip impingement and labral tears daily. I'll probably see anywhere from 10 to 20 people a week that come in to see me for hip issues that are younger or even, in their middle ages with hip issues. When I diagnose them with hip impingement or diagnose them with a labral tear, I always start with conservative treatment. That usually entails physical therapy, focusing on hip and core strength. A lot of times, the stronger you can get your core, the stronger you can get your hip muscles. It helps support the hip more, and you can really get symptomatic relief from strengthening the hip. I think it can be very, very beneficial. I always recommend that. Activity modification can be another important thing. I always ask patients, what really bothers the hip? What flares it up? Usually it's running, deep flexion, getting down in a kneeling position where you're squatting really deep. Sometimes that can be really irritating to patients. So I always tell them to really try to make a journal of what irritates it and try to avoid those activities. Sometimes it's impossible to do. Injections can be helpful. There is a lot of different types of injections you can do for hip impingement or labral tear. Uh, a lot of people are very familiar with cortisone injections, where you inject steroid in the hip. It usually provides a really good anti-inflammatory effect, which treats the pain. And there's a lot of newer injections that we've been using, like biologic injections, such as PRP, where you can actually take your own blood, spin it down in a centrifuge, and inject it back in the hip for pain relief. So I offer that often to my patients. And another reason I like to do an injection is sometimes I can use it for a diagnostic purpose. If we inject the joint and the pain goes away, even for a short period of time, we can kind of confirm that it is the hip joint or the labrum that's causing the pain. So we do that very often. NSAIDs can be very helpful too, such as ibuprofen, Aleve, or meloxicam. I often prescribe those medications to be taken as needed for patients with a labral tear or hip impingement, and it usually provides a really good relief response. So in those patients that we start on this treatment path, with weeks to months of conservative care that have persistent pain, there is a good surgical option, and that's when I kind of come in and talk to them about what that entails. So I typically recommend, failure of all the conservative cares. If that doesn't work, we really evaluate if you're a good surgical candidate. And I think a lot of younger people, even people sometimes in their 40s and 50s, can be a candidate for this. But it all depends on the health of your hip joint. And what I mean by that, I see people daily or weekly that come in to see me for a hip scope. And when we get x-rays, like this top one right here, they have a lot of hip arthritis. And what that means is the space in between the ball and socket joint starts to obliterate, and those two bones start touching each other. So the top one is an arthritic hip. You can see this bottom one here is more of a non-arthritic hip. These are the patients who do the best. If you try to scope a patient that has extensive arthritis or even mild arthritis, the outcomes are really not good whatsoever. And what can happen is you can scope it and they have persistent pain. So those are the patients I talk to about other options, such as a hip replacement. But typically, the ideal candidate for a hip scope are people with a labral tear, with the hip impingement type morphology on x-ray, that have a good looking hip, that really have hardly any arthritic change. The other people that I see often with a hip labral tear that really are not good candidates are people with hip dysplasia. And typically what hip dysplasia is a shallow hip socket. And sometimes if the socket doesn't cover the ball and it's really shallow, and you try to scope the hip or do a hip arthroscopy procedure on it to repair the labrum, the outcomes are not nearly as good. So typically I think people with arthritis or hip dysplasia are typically not good candidates for the hip surgery. And the important question is, how do I do this? So we actually do it at the surgery center right here, at the surgery center in the Fox Valley. It's an outpatient surgery. You do have to go under general anesthesia to make sure you have no pain and that you're fully relaxed. And we actually put you on a special table where you can actually hook your legs up to these boots, and we can kind of pull traction on these bars to distract the hip joint. We have to distract the hip joint, as you can see in this top picture, to get my instruments into the joint itself. So you just distracted a couple centimeters to open up that space to get the instruments in the joint. So general anesthesia is necessary. A special hip table is necessary. That is one of the complications of this surgery too, is you do have to pull traction on the leg. So there can be some issues with back pain, knee pain, ankle pain from some of the pressure that's applied to that leg. But once we get the scope in the hip, you can see on this left picture here, this is a pathologic hip. And what I mean by that, this is where you can see there's a labral tear. This is the socket right here, this white area. And this little bumper on the outside here is the labrum itself. This is a metal arthroscopic probe that can kind of palpate that tear, but you can see where there's separation between the labrum, which is the gasket of the hip, and the bone itself, where it tears right through there. So typically what we do is we trim away any of the bone on the socket that's getting pinched, and then I put bone anchors into the bone that have suture in them, and we can reattach the labrum with bone anchors and suture to get a really nice repair. And you can see where that separation was, it's completely reattached here in this second picture here. So that's what we call labral repair, and trimming of the socket side of the hip. As I mentioned previously, a lot of people have extra bone on the ball side too, as you can see in this picture right here. This is what we call that cam lesion, where you have extra bone on the ball, and that will still impinge on the socket. So you have to trim away that extra bone with a burr. And you can see this is a picture of one that's been performed where there was all extra bone right there. And after you trim it, you can see where that pink and yellow bone is now, is where all the extra bone was. And now there's no more extra bone there to impinge on the socket to cause another tear of the hip labrum. So if you didn't trim the bone on the ball side or the femoral head, what would likely happen is it would lead to recurrent pain and a recurrent labral tear. So it's really important you address both sides of the hip, the socket, and the ball. So like I said earlier, it is outpatient surgery. It's done through just 2 keyhole incisions. It's all done through the scope and just, these small instruments that I can stick into the hip joint. Typically, people for recovery wear a hip brace for about 4 to 6 weeks. And I have a picture here on the right side. It's kind of a brace that goes around your waist and your thigh to help stabilize the hip. It just provides some support for the hip while during the healing process to make sure nothing bad happens. For some patients, I will prescribe a motion machine too, which is called a CPM machine. And what that does is it moves the hip to prevent any stiffness. And you do that a couple times a day for a couple hours. Most patients actually really enjoy doing it. Just kind of provides some pain-free mobility, and it feels almost like a pain reliever for patients. So I actually often prescribe that. And the nice thing about this surgery is you can still put about half of your weight through the surgery immediately. So you don't have to hop on the crutches. You do need crutches or a walker, but you can put about half of your weight through it for about 2 weeks. When I see you back in clinic in about 2 weeks, if things look good, then we've slowly progressed you to full weight bearing. So I would say around 3 weeks, 4 weeks, people are ambulating very nicely, getting back to their normal activities, driving, going to work, as long as if it's not strenuous. Physical therapy is just as important as the surgery itself. So I prescribe physical therapy for all patients, usually about 8 weeks, sometimes 10 weeks, where they work on mobility and gradual strengthening. I would say that's just as important as the surgery itself. If you don't do the therapy, the outcomes can be compromised for sure. And full recovery, getting back to sport, working out, no pain, full mobility, full strength, usually between 3 to 6 months. I've operated a lot of collegiate athletes who have returned to sport around 4 to 6 months with no pain, full motion, good mobility, and good strength. So that's kind of the timeline I always talk with patients. The other question I get a lot too is there anything else that you can treat with a scope besides hip impingement and a labral tear? And there is one other thing that I often see in clinic where patients can be a candidate for a scope. And this is a little bit different location of the hip. We were talking previously of the hip joint itself where the ball interacts with the socket. There is a lot of patients that can develop pain on the outside of their hip. And what's that called is an abductor tear or chronic hip bursitis or trochanteric bursitis. And that's where the muscles attach to the outside of the hip bone. That's called the trochanter right there. Typically when people have this type of pain, it's not necessarily in the groin, but it's more on the outside. A lot of people have pain when they're laying on that side at night. It can wake them up. It can alter your gait where you start to walk with a limp because those muscles that attaches the hip bone right there can tear and they can weaken, and your leg doesn't function appropriately, so it causes you to limp quite severely. So when I see these patients in clinic, I always kind of decipher between, is it groin pain or is it more outside hip pain? And typically an MRI, when I order that, can kind of show if there is a muscle tear on the outside of the hip. So it's a pretty distinct exam, very different from a hip labral tear. When I see people with chronic hip bursitis or a muscle tear on the outside of the hip, again, we always try the therapy route first. There's injections you can try, such as a steroid or PRP. A lot of times time itself can resolve this issue. But if it doesn't, there are ways where you can go in there with pocal incisions again and repair the muscle with bone anchors right here in the right-hand corner. And a lot of times you can also take out that little bursa sac at the hip bone to get rid of some of that pain on the outside of the hip. So this is something I do as well. I would say it's less common than a labral tear or hip impingement, but it's something I see quite often as well. So those are the three things I typically focus on when I talk about hip scopes. I probably spend more time with patients, probably talking them out of a hip scope because I don't think they're a candidate for it. But when you come see me in clinic, usually a combination of the exam, you're looking at your x-rays, looking at your MRI, we can kind of figure out if a hip scope is something that you would benefit from. So that's the majority of my slides. I know I'm open to questions like Lauren mentioned, but I kind of want to just provide an introduction and kind of a brief overview of what I do here with the hip scope and see if there's any questions out there.
Great. Thank you, Dr. Nabor. Yeah, like Dr. Nabor said, if you guys have any questions, feel free to put them in the chat or the Q&A and we can get those answered. If we don't get to your question tonight, if for some reason we don't, we do encourage you to give us a call and schedule an appointment. We'd love to be able to get your questions answered for you. As of right now, we'll get started with the Q&A session. So let's get our first question going. Dr. Nabor, what are the main symptoms that might indicate that someone could benefit from hip arthroscopy? I know you kind of did touch on that a little bit, but
Yeah,
just
so I think the main one for hip impingement or hip labral tear is groin pain or pain in the front of the hip. Usually it's worse when sitting. Usually it's worse with like long car rides. I'll ask patients, say, when you go for a long car ride over 20, 30 minutes, you start to feel like a burning sensation in the front of your hip and you want to extend your hip because of the pain. That is a patient that I think probably has hip impingement or a hip labral tear who I think would benefit from an evaluation. For the bursitis type pain, it's more pain at night, pain laying on that side, and it's all on the outside of the hip. It can radiate down the outside of the leg. So that's more of the hip bursitis type pain.
good to know. All right. And I know you did kind of touch on this too, but just to reiterate, like, how do I know if I'm a good candidate for this type of surgery? And, you know, if you determine that I'm not a good candidate, what are some like ulterior routes that you take to help determine what might be the best treatment option for me?
Yeah, I think the best candidates, in my opinion, are the patients who have been experiencing pain for quite a while. I don't really recommend proceeding with surgery. You know, if this is like an acute type injury, if it's just weeks or days out, I typically recommend really trying everything you can to avoid a surgery. And then again, that's a combination of physical therapy, anti-inflammatories, injection therapy. If those fail and your hip does look good without any arthritis, and like I don't really care about the age, you know, I think the older you are, the more risk you have for arthritis. But if we have an MRI and X-rays that look at your hip and it looks healthy, and all you truly have is a hip labral tear, then I still think you're a candidate. But it all comes down to what your hip X-rays look like and what your MRI looks like.
Do you ever have any cases where you go in and there might be a labral tear, but you may also see that there's deterioration to the hip and it might turn into a hip replacement or something else?
I try to avoid those cases, but I have had cases where the MRI or the X-rays don't tell the full story. Where you go in with a scope, it actually magnifies the joint space. And I have had some patients where I get in there and it's kind of surprising how much arthritis actually affects the joint. So if that's the case, you still can perform the surgery, repair the labrum, clean up the arthritis. But that's when you start to worry about the outcomes not lasting as long. I still think those patients get improvement of their symptoms, but it's less durable. What I mean by that, you know, it could last, you know, months to years versus like 10, 15 years for somebody without arthritis.
Thank you for that insight. So someone mentioned that their hip MRI was normal. The X-ray showed impingement. They had a workup with thoughts of PSOAs, a muscle strain with injection with no relief. So they continue with groin pain, especially with yoga motions. Mild arthritis, age 66. Could this potentially be a labral tear?
Yeah, I think MRIs are not perfect, especially in the hip. So I see this actually fairly often. I had 2 discussions with patients today where they came back with a relatively normal-looking hip MRI, but the exam was very, very specific for potentially a hip labral tear. What I'll do in that time when I'm a little concerned about it, I don't think the MRI is diagnostic. I will do a diagnostic injection into the joint. It sounds like you may have had an injection into the tendon sheath, which is a very different location. So if the injection of the tendon sheath did not improve your pain, then I would inject the hip joint. And that's where, if you had a labral tear, the pain would get relieved even for a short period of time because the joint is where the labrum would be affected, not the tendon.
Great. All right, let's see. Are there any alternatives to an hip arthroscopy if there's someone who's not necessarily ready for surgery? I know you kind of touched on injections, so.
Yeah, I think injections are a good option, whether that's steroid or whether that's PRP. I caution patients, I think it potentially could be temporary, but sometimes I'll have a college athlete or somebody who, let's say in their middle age, is going on a big trip to Europe and they're going to be hiking and biking a lot. They just want to feel better, but they don't want to necessarily go through a big surgery. I think those are the patients that are really good candidates to try an injection because one, it's a diagnostic test to determine truly if they get relief from it. And two, if it works, sometimes it can last for months, sometimes even longer. So I don't recommend repeating them over and over again, but I think one or two here or there during an important event in your life, I think can be very, very helpful.
And it sounds like most cases too, it's unique for every patient.
Correct.
How long should someone try conservative treatments like PT or injections, rest before they do consider surgery, or if they're working with you before you would consider surgery?
I kind of go around that 6 to 8 week mark. I think if you're dedicated with a conservative route with the therapy, injections, medications, and you give it your best chance to get better, and 6 to 8 weeks of no relief with dedicated time, I think that's a time where you can start considering it. I would say around 3 months, and I would say I definitely think that's probably enough time to at least attempt a conservative route. If that doesn't work, then I start at least having that discussion of a possibility of intervening with surgery at that point.
Looks like we have a few more questions, so we'll keep going through those. Are there any risks or potential complications associated with a hip arthroscopy that people should be aware of?
Absolutely. And I think that's a hugely important discussion I have with every patient before they have surgery. So anytime you go to surgery, there's general anesthesia risk. So always make sure, cardiovascular, you're healthy. Things that you can optimize: diabetes, any type of blood thinners. We have to be careful to avoid that type of stuff during surgery. So we usually have to hold that type of stuff or make sure the diabetes is controlled. Infection risk is exceedingly low, like almost unheard of, probably less than 0.5%. So theoretically, it could happen. I have never seen infection in a hip scope, and like I said, it's been done over around 400 of these. So that is not something I worry about. I always caution patients it could happen, but very, very rare. I would say the biggest risk for that I talk to patients about is if you truly have a labral tear, we go in there and fix it, and for some reason you have a little bit more arthritis than what we expect. Sometimes the outcomes can be less predictable. That would probably be the biggest risk for me. There's always a chance you could re-tear the hip labrum if you were to have another injury. So that's another potential risk factor. You could develop stiffness. That's why therapy is really important. And I always tell patients with the traction, because you have to pull hard in that leg to get the joint space open, it can lead to, irritation in your hip. It can lead to irritation in your back, your knee, or even your ankle. From traction, I would say if it does cause sensitivity, usually within days to weeks, that completely resolves.
Right. And you mentioned that people may re-tear their labrum. How could a labrum tear happen in the first place?
So I kind of break it down to, traumatic tear versus more of like a kind of a genetic predisposition to having that tear. So if you have a car accident, you have a traumatic injury playing football or basketball or pickleball, and you had no pain, you tweak it, you feel a pop, and it feels painful after. Usually that's from the trauma of an injury. The most common tears I see, like I previously mentioned, is when you have extra bone on your ball or when you have extra bone on the socket. Those two bones can impinge together And that alone increases the risk of developing a tear. And that can happen just from normal everyday use.
All right, we've got a few more questions, so we'll keep going. What does the physical therapy involve that you prescribe for patients?
The first couple of weeks, it's all about mobility. We don't really care about strength. All it is just kind of preventing scar tissue from forming. So that's what's important, is just to keep the hip mobility, get swelling controlled, making sure you're moving your ankle, moving the knee, and kind of working on your gait training. After about 2 to 4 weeks, then it's more like kind of normalizing your gait to kind of get your ability to walk well. After about 6 to 8 weeks, that's when you start really focusing on like your strengthening and getting like back that muscle mass to return to sport or get back to, playing pickleball or walking around the block, whatever you wish to do.
Yeah, and we do have those physical therapy protocols on our website. So if anyone misplaced them, they can always get them. But that is something that our physicians do print off for people and make sure that you have, so that you could be reminded of what it is that you're specifically supposed to do and when you're supposed to do it. And then how soon do people normally return to their activities or their sport after this? I know that you said that it's a few weeks, that like 4 weeks that you said that it takes for them to walk again, but how about performing those sports or even gardening or doing an activity they like to do?
I think, low impact activities such as gardening, walking around the block, walking on a treadmill, usually around 6 weeks, 8 weeks. I think is totally reasonable to at least try to do some of those things. Getting back to playing more high impact sports, jogging, running, the cutting, pivoting sports such as pickleball or basketball, soccer, I'd say you're looking more 4 to 6 months. Usually competitive athletes, talking about, collegiate athletes, I usually tell them around 6 months before they're really getting back to their activity level where they were before.
All right, it looks like we have one more question. So if anyone else has any other questions, we'll try to address those afterwards, but otherwise we can have this be the last one. What advice do you have for people that are going into surgery or are going to be recovering from surgery? Do you have anything specifically you'd like them to know?
I think what I tell patients, really with any surgery, especially the hip arthroscopy, is you have to be mentally prepared for the recovery. I think you have to get everything in order, your work life, your family life. You have to make sure that your hip truly is symptomatic enough to go through this. But I think if you just jump into it without planning appropriately, your outcome can be compromised, because it does take a toll on everything for a period of time. You just have to be mentally prepared to recover and be dedicated to your therapy, and don't take shortcuts. So I always just tell patients, it's not emergency, it's elective surgery. You can pick a time that works best for you. And that's best for your family and your work too.
Yeah, great advice. All right. Well, it looks like that is all the questions that we have. But like I mentioned before, if there's any questions that you have that weren't answered or that you think of after this, of course, please give us a call. Our number is 920-430-8113. Otherwise, you can schedule an appointment online at osmsgb.com. Like I also said before, too, we're recording this webinar, and that'll be up on our website by sometime next week. So if you want to come back and refer to anything that Dr. Nabor mentioned, or if you have someone that you may want to refer this webinar to, you can do so as well. Otherwise, thank you again for joining us, and we hope you have a great night.
Yeah, thank you for your time.